Hi, this is Brian Kim. I want to share with you this long-awaited video of Cataracta Nigra Part 2. So if you look back at my videos on December 2nd, 2023, I uploaded a video called Cataracta Nigra where I struggled to phaco this lens, this super dense black lens, and I started to lose the pieces into the vitreous space. I had posterior capsule rupture, so then I quickly converted to an M6. And I did the best I could to remove the lens pieces without losing any pieces, and then basically closed up the eye. And so this is part 2. Again, if you're not comfortable with dealing with this situation, if it was really stressful, why put in a secondary lens in a stressful situation? The case is already long. You have a whole bunch of other cases to do. And so it really makes sense to just pause, stop, go ahead and close up. Do a good job, of course, cleaning everything out. I did a good vitrectomy. And now going back here on this video, showing Yamane scleral fixated lens using a Sensar IOL on this Cataracta Nigra case, part 2. So again, you can see this patient is aphakic, now with a nice and clear cornea, big pupil. You can see a remnant of my capsule on the right side here. I'm using a wax cell to dry the surface aggressively, because you have to have a dry surface to get really nice and discrete ink marks. Using the tip of the 27 gauge cannula, marking the right side, and then using the cannula to find 180 degrees apart and marking the left side. Using the fixed caliper, indenting the sclera 2.5 millimeters posterior to the limbal mark and then 2 millimeters adjacent. And then doing the same thing on the left side, indenting the sclera 2.5 millimeters from the limbal mark and then 2 millimeters adjacent. By having a fixed caliper, you don't have to constantly try to measure and remeasure and moving the dial. I'm able to mark the indentation with the tip of the 27 gauge cannula, first on the right side and then the left side, using that wax cell sponge to dry the surface and then mark. This really increases the level of precision for scleral needle placement. This is the trocar. I'm indenting the sclera with the back end, 4 millimeters posterior to the limbus, using the cotton tip to turn the eye, tunnel towards that mark, about 3 millimeters, staying tangential and nice and shallow, and then turning perpendicular and diving down. You can see the trocar cannula is leaning sideways, which means that's a nice scleral tunnel. This is my 1 millimeter diamond blade. That first incision is for the AC maintainer. Turning the eye towards me in order to make my incision, again, 90 degrees from the marks, contra-incisionally. That is going to be to externalize the leading haptic through that contralateral limbal incision. And these are our other marks in case I have to do more vitrectomy or any other manipulation. I'm making my incision on the left side. This is intracameral epinephrine. As I said, I already did a vitrectomy. This is going to stabilize that pupil. And this is dispersive viscoelastic. Trying to coat the cornea, but of course I did vitrectomy. It's hard to know how much coating I'm going to have with the dispersive viscoelastic. And this is the 3 millimeter blade. I make a groove and then tunnel through the cornea and then enter. Again, I am 90 degrees from the marks. This is a 25 gauge cannula, bending fairly close to the tip, bending the needle in such a way that the bevel is going to face to the right when I'm holding it up. And this is the right side needle. Again, I'm going to have the bevel facing towards me. As I bend the syringe up, I want to make sure that the bevel is facing towards me, and I'm bending it about 9 millimeters from the tip. And you can see each of these needles are mounted with a syringe full of BSS. This is the left side needle, bending the needle at the hub in such a way that the bevel is facing away from me. This is the 22 gauge thin-walled AC maintainer. I'm going to high mag here. You can see that thin wall. And the nice thing about this is I don't have to widen the incision. So it's really beautiful. Irrigating the surface, stick it right in. It's diamond dusted so it stays nice and snug. Use steri strips to hold it down. And this is some cohesive viscoelastic filling the chamber of the cartridge. This is a Sensar lens, seating it down, making sure the wings are apart as I'm trying to seat it down. And then as I bring the wings together, the leading haptic has to go straight into the barrel. The trailing haptic has to come out through the back, and the lens has to bend concavely. Placing the cartridge into the injector and making sure the trailing haptic is out of the barrel. As you see here, advance the plunger so that it doesn't hit the trailing haptic, and I advance the lens so I can see it through the cartridge. Placing the 25 gauge needle through the contralateral limbal incision, placing my injector, turning the bevels toward each other, advancing the lens. My technician is doing that. As she advances the lens, the leading haptic comes out. I dock the haptic on the bevel of the needle. She keeps advancing, pull the needle out, and the haptic comes out with it. I take over, and then the optic comes out, and the trailing haptic is made sure it's facing to the right. Again, filling some more dispersive viscoelastic to push the lens back and to coat the corneal endothelium. Holding the trocar with forceps. This is my, again, right side needle, 30 gauge thin wall needle. I'm stabbing into the conjunctiva and sclera, making sure I'm flat, tunneling 2 millimeters, and then diving down. This is perfectly executed, making sure that the marks and my intended scleral needle placement matches. You can see the bevel is facing towards me. And by doing it this way, I'm able to make sure the curve of the haptic is facing towards the bevel of the needle. That's why I do it this way. I'm pushing some more viscoelastic. I think it's because the AC maintainer was getting caught on the optic. And using non-tooth forceps, I'm grabbing the trailing haptic, but I'm sliding it sideways. You can see I'm doing a very gentle sideways slide maneuver. By doing it this way, I'm not bending the haptic at all. I had to do that wiggle movement because the capsule got snagged with the needle. So you can see because I have the bevel facing the curvature of the haptic, I'm able to dock the haptic on the bevel of the needle, and I'm able to use my right hand and just rotate my wrist in order to make sure that the angle is proper. So right there, I dock the haptic. If I'm having trouble, I just stop, reposition. I'm pronating my wrist, and when I did that, the bevel was better aligned with the approach of the haptic. I was able to dock the haptic on the bevel of the needle, and it slid right in. Again, 2 pushes is all you need. You don't really need a whole lot of haptic to be in the needle because this Sensar lens haptic grips the needle so well. Disengage the needle from the syringe. Internalizing the leading haptic into the angle. And now I'm going to focus on the left side. Again, this is all about keeping a nice firm globe while trying to execute the tunneling of the needle through the sclera. So I'm stabbing through the conjunctiva and sclera through that first mark. And you can see that other mark is moving around, but I kind of had a picture of where it was because I first stabbed initially at that first mark, so I know where I'm supposed to go. I'm able to tunnel 2 millimeters, and then I dove down. Now you can see the left side needle, the bevel is facing away from me, but it's going to face the approach of the haptic, the curvature of the haptic. Again, holding the haptic perpendicular with the smooth forceps. I got a little bit caught on the needle, but you saw I just repositioned it, docked it again, and slid right in. So again, I only do a couple of pushes. Go ahead and pull that left side needle down towards me, making sure I have microforceps to grab the haptic at the same time, making sure not too much of the haptic comes out, cauterizing the tip. Doing the same thing on the right side, but because the needle came from above, I'm pulling the needle away from me. As I pull the needle away, the needle comes out. I grab the haptic, make sure that not too much of the haptic comes out. So I just keep pulling it in with the forceps, grabbing the haptic, and then cauterizing the tip. You can see the nice flat position of the haptic, flat to the sclera, which means I have a nice scleral support. That means that the lens is going to sit in the proper position. By being flat, that means it's the opposite of the flagpole sign. If I had a flagpole sign, that means there would be insufficient support of the haptic, which would result in sagging of the optic and tilt. Go ahead and placing a 10-0 nylon suture. And this is the vitrector assisted PI. I'm going through a contralateral incision with the vitrector with the tip port down. Again, there's a special setting for this. It's a low cut rate. Go ahead and grab the iris, get some occlusion, and then eat that iris. Again, I try not to stay too far into the periphery because you don't want to eat the ciliary body. Switch to vitrectomy, making sure there's no vitreous in the anterior chamber. As well as going underneath the lens and doing a little bit more vitrectomy as well. Again, I did vitrectomy before, so I'm very confident I'm not going to have any vitreous. So again, I did vitrectomy during the original case, so I'm confident I'm not going to have vitreous with this case. Go ahead and hydrate my incisions, and you can see a perfectly executed Yamane case. The lens is perfectly centered. I had a nice low profile of the haptics, which means I had nice scleral shelf, scleral support of the haptic, which means it's going to have a good refractive result, more properly simulating the lens within the capsular bag. Pulling the trocar out, tamponading the sclerotomy with the cotton tip, activating infusion, and as you see, there's absolutely no leakage from the sclerotomy, because I made a nice scleral tunnel. Taking the 22 gauge thin-walled AC maintainer out. Closing the incision. Because it's such a small AC maintainer, you see there's no leakage from that incision because I did not have to widen it. So there's a clear cornea, perfectly executed Yamane technique. This patient previously had that giant cataract, Cataracta Nigra, which I posted again December 2nd. That was a really terrible case. I got a lot of views and a lot of comments on that case. Of course, there's a lot of MSICS masters around the world, not so much in the United States. So I was able to do the best I can, very carefully following the principles of MSICS, got through the case, and then said, you know what, I'm take a deep breath, come back another day. And this patient was ecstatic with his vision after the surgery. Again, he really put off this cataract for a long time, but I'm glad we staged this surgery, took out the cataract. Again, in the context of posterior capsule rupture and the lens descending into the vitreous space, I think considering that circumstance, this is the best situation. I converted to M6, got those lens pieces out with a lens loop, which again, they were huge, dense pieces, the densest I've ever seen. Cleaned up the vitreous, closed the incisions, and then came back and performed this Yamane technique. Again, my standard technique, externalizing the leading haptic through a contralateral limbal incision. This allows you to perform the Yamane technique with the delicate PMMA haptics of the Sensar lens. I was able to execute it without any difficulty. Again, part 2 of this Cataracta Nigra, my modified technique with the Sensar lens. So I hope this was helpful to you, and I thank you for your attention.